there should be a societal commitment to improve metabolic health, to talk about education at schools, nutritional education. And that kind of goes the same way that we discussed with Jeff Lazarus on this podcast, to implement more broad concept of living healthy, where people then can go on to lead a life that supports liver health. Time is the best ally to try to prevent something or revert certain stages. If we identify them late, we might have a tougher task. And I think parts because the disease progressed based on biology and maybe the scar is built up stronger. But the other aspect is that certain habits that build over time are more difficult to change when you get older.
Hi, this is Roger Green, host of the Surfing the NASH podcast. Today we are offering our final conversation from episode 63, the second of our three-part year-end series. The episodes offer shortened conversations with our opinion leaders. This piece shares our entire conversation with Jörn Schattenberg about cost of living, quality of life, and general developments in NASH during 2021 and the years ahead. This conversation represents a candid, detailed discussion with a major opinion leader on a subject he discusses passionately. So sit back, listen, enjoy, learn, and when you're done, join the discussion on our LinkedIn and Facebook discussion groups. Now we are here with our good friend Jörn Schattenberg, who I have taken to affectionately and respectfully calling the fifth Beatle, which I guess kind of mutilates the surfer metaphor a bit, but the Beach Boys didn't have anything like a fifth Beach Boy. They always had tumult and chaos. So we're going to have to go with fifth Beatle. Jörn, how are you today?
Oh, thank you, Roger. I'm fine. Good to see you, Louise.
And you, Jörn.
And Louise and Jörn, as you'll see when you see the after picture, are dressed in matching black, making my white a little more offset. Not sure what to make out of that, but I'm not going to worry about it terribly much either.
We've just got excellent taste for Christmas.
You both have excellent taste all the time, and you like each other, which is a good thing. And in fact, the combination of Louise being blonde with black shirt and Jörn being dark with the black shirt, it's really good. Works. My graphics and artistic directors approved, and the sleeves really make it. Louise, you have to put the sleeves up when they take the picture at the end, so someone knows what we're talking about.
It's my snow shirt.
I know, it's a snow. So, at any rate, we gave Jörn the remarkably broad topic of anything he chooses to cover in the areas of AI or cost effectiveness. AI, because everyone knows it's important, and cost effectiveness in part because we know that cost effectiveness is going to be pivotal to getting fatty liver accepted in the place that it belongs, and that Jeff Lazarus actually mentioned some of Jörn's work as being really helpful to the effort that is going on in Europe and around the world. So Jörn, kind of what happened in 21? What do you see in the years ahead? And it's a big topic. Start wherever you want.
Well, yeah, thanks, Roger, also for giving me an opportunity here to think back on 2021. I think it's been an amazing year. It's been challenging in many aspects. It's been another year of mostly not being able to meet in person. And for that reason, every time I come on NASH Tsunami, this feels to me like being able to discuss science and emerging topics in the field with friends and colleagues and peers. So really, NASH Tsunami has carried me through another year of absenteeism with regards to in-person meetings. So I think this is exceptional. And if you think back to what happened over the year, it's been also an exceptional year for non-alcoholic fatty liver disease, because we've seen 3 New England Journal papers coming out. That's not a typical thing to happen for one single indication. It shows you the momentum we're seeing here with regards to drug development. 2 of those papers, one on the SEMA phase 2 and one the lanifibranor phase 2, we discussed at length in this podcast. But then a third one talking on the natural history of the disease, and it comes from the NASH CRN, and Rune Sanyal is first author on that, detailing endpoints, mostly liver-related endpoints in liver biopsy-defined population being followed for 4 years and more. So we're learning on relevant endpoints in that population. That brings together many aspects we've been discussing here on the podcast, namely, why is it relevant to study the disease? Will the patient do reach liver-specific endpoints? How could we do that? And there's a number of MOAs being explored. And if you look back to the failures, it follows the same theme. The discussion around what's the best endpoint, why is there so much noise in liver histology? We've seen improvements in NITs with the aldafermin data, which we thought might translate into benefit if being followed for longer, but still the program was discontinued in the non-cirrhotic population. That summarizes many aspects that have been key for me when I think back to 2021. When you ask me to talk about cost effectiveness analysis, of course, that's another big step here. And a study that we did this year was with many European colleagues together. Vlad Ratziu is the last author. I serve as first author on a manuscript that was published in Liver International. And we took out to study the disease burden and the economic impact of diagnosed non-alcoholic steatohepatitis across Europe. So this is a cost of illness analysis that was published here. And not being a health economist, but if I'd like to have to summarize that paper for you in very few words, I think it's important to dissect, or what I learned when talking to the health economists that helped us to build that paper, is that there are, of course, many different methodologies to do this and estimates to reach that. And there are, on the one side, economic and well-being costs, and on the other hand, direct medical costs that you can assess. That's a very important aspect that have to be considered here. In the end, the approach we took in that paper is that we sat down and discussed with colleagues and tried to assess how many of the patients we're seeing are actually representative of the overall patient population. We asked the question, how many patients are diagnosed with NASH, because that would affect the amount that is spent. Bottom line, I think there are two messages that come from that paper. I think across Europe, there's very diverse numbers in terms of how many of the prevalent population are actually being diagnosed. I think in Germany, we agreed that the more advanced disease stages would be more readily diagnosed. And based on the different referral pathways, we're seeing patients in clinics with elevated LFTs, not so much dependent on the disease stage, but many patients are being sent when their LFTs are being elevated. We do see a different patient population compared to the UK, where you do get referrals based on standard referral pathways. And in the end, it turned out that the majority of patients, particularly in the early stages, are probably underdiagnosed, and most of the money we spend, or most of the economic expenses, are made in the end-stage liver disease population. I think those are two very important findings when trying to come up with models and cost estimate for this disease.
Take a breath. That's a lot. First of all, it's a lot. But the last sentence, or the last two couple of paragraphs are a lot. When looking at the cost of diagnosed patients, the cost we see is the cost of end-stage disease. The overall health economic number in the States several years ago, when I was doing this stuff more regularly, was that about half of all healthcare expenses in the U.S. came in the last 6 months of life. Period. But when you say the disease is underdiagnosed and all the spend is late stage, then I'm going to run around to Louise's side of the table and ask, how much of that money would you guess, underline the word guess, could have been saved with better early stage diagnosis patterns?
I'm going to say a lot if we take into NAFLD, and that steatosis isn't benign. So finding early stage poor liver health is, to me, important because it changes the trajectory. If we find somebody in their 20s and we make minor changes there, we don't see, we would hope, the costs. And whilst I appreciate the argument of we need data, we need evidence. We're getting evidence after evidence of the other way around, that when obesity strikes early, we now have children born to parents who are overweight. But those parents statistically would have been born to parents who were normal weight. So we are moving the framework of everybody's size. I think that's been covered quite a lot. It was covered in the EASL meeting earlier on the year, and the keynote speaker. It was covered recently in a Lancet commission by Jeff Lazarus and the team. So I think for me, it's about early opportunity to stop something. Now, and just to pick up on Jörn's point on cost effectiveness, I'm going to ask a stupid question here. When I appreciate cost effectiveness, but every life to me is a life saved, whether or not it's early or not. But it only seems to become cost effective when we're talking about 1/4 of the population of all of our countries, when we put a very big expensive drug at the end of it. So it's a pharma outcome that requires us to then say it's cost effective not to spend hundreds of thousands on a drug for somebody, when that's adding an extra cost into the framework to then make looking for it cost effective. Maybe I'm just simple, but that doesn't really make sense to me, to add more expense to then start looking to be cost effective. Surely saving a life at a younger age. And we die at liver disease on the average of 57 in the UK. I'm not too sure what the German statistics are, but to me, that's more than cost. It's societal cost. It's working life lost. It's all of those other costs that we seem to only worry about when we stick a big number, because X drug is going to cost X amount. We better find it quick. Explain it to me.
That's not easily explained. And again, I'm not a health economist here. Roger can give his thought maybe on that. But the point you're addressing, I think, is if we spend money on diagnosing fatty liver disease is the mirror of the unhealthy metabolism. It reflects an unhealthy person that's going to develop a metabolic complication. Now, that's not necessarily going to be cirrhosis with cancer or transplant. A cost-effectiveness analysis trying to explore liver endpoints falls short to capture the benefit of that patient. And that brings us to a central aspect of all these analyses, is the competing risk. So if the young male with a fatty liver on elastography will be screened and counseled to avoid his diabetes or to avoid his cardiac or stroke, myocardial infarction, that's a benefit that needs to be accounted for. And it's not going to be captured when aiming to improve liver health necessarily. This is one aspect. Yes, you can spend money on liver screening. It's easy to detect fatty liver. The benefit is there, but not necessarily for a liver endpoint in the time frame we're looking at. I think that's one point I'd like to make. And you made another good point is, why do we start to worry about patients with cirrhosis trying to avert or affect their outcome? Well, the truth is many patients with cirrhosis are already in the clinic, so we do need an answer for these patients. But I'm with you that there should be a societal commitment to improve metabolic health, to talk about education at schools, nutritional education. And that kind of goes the same way that we discussed with Jeff Lazarus on this podcast, to implement more broad concept of living healthy, where people then can go on to lead a life that supports liver health, I think.
You are, and I think both of you make great points. Louise, I'm going to try to answer your question, not because I agree with what I'm about to say, but because I think it's how the world works. Usually, people run health economic analyses when they're trying to justify what they are spending, not justify what they're not spending, or not to get justification not to spend, unless they're trying to justify something easy, and a drug is easy, okay? So if I want to justify the drug, I simply see what it costs to spend on the drug. I get some parameters around where do I think I might be saving money. I ask myself, am I saving enough money? You can't really do an analysis on what's not there with rigor unless you have really solid numbers about the percentage of the population you're evaluating for which it isn't there. So if you take the number that NASH is 5% of the population, or the number that NASH is 14% of the population, and we're looking for early stage NASH, and can we reduce the rate of heart disease or diabetes or other kinds of morbidities and mortalities, you got to know what number you're starting with. And people have a hard time agreeing on those numbers, therefore they have a hard time running that analysis. They teach you in business school that folks do what's inspected, not what's expected, and therefore there's a self-fulfilling cycle, which is the things that can be inspected are the things that get valued, whereas the things that have greater value may never be inspected because there's nothing to inspect. And you go back to the comment Jörn made about the liver as a mirror of the metabolism. That's non-quantifiable. And every time we quantitate it in the context of a specific disease that occurs when the liver is not acting in balance. So it's easier to look at how do you validate the cost of diabetes than to say, okay, how much of that cost is fatty liver? What happens if I take fatty liver out of play? And that's the thinking that we're going to need to do ultimately to get our arms around this, right?
Yeah, absolutely. My concern are papers like Tracy Simon's work in the adolescent population, biopsy-proven NAFLD in 17-year-olds. 1 in 15 was dead within 20 years. We do not bring up our children deliberately to see them die young of cardiovascular disease and extrahepatic cancers, which I think were the two biggest causes in that study. And that was a fairly robust study from recollection. And gaining that evidence, it's about when do you therefore say that it is effective to look at population screening in obesity. The high-risk groups, I do appreciate that, yes, one part of me does. I think everybody should, on the NHS or anywhere, have a baseline complete body review. We MOT'd our car today, and it was a case of it got a full tick over in all of the major components. We don't do that for people. If that starts earlier, it becomes, to my way of thinking, more cost-effective the earlier you start it. But to pick up on Jörn's point about education, I recently had communication with somebody who tried that in a school in the US, to be fair, about increasing awareness of nutrition and diet, to be told we can't do that. People get eating. If we focus on diet and nutrition, people get eating disorders. There was an obstruction at every level. It's not about focusing on nutrition. It's focusing on health. It's focusing on the general. It's not focusing on your particular diet and how you do. It's focusing for me on how your body works. We'll all choose to do different things in our life and treat with excess. It's the season of foie gras. Now, we're going to do it, but we're going to do it most of us will do it in moderation, and then we'll tailor it back a little bit. But for me, prevention, we're seeing the culmination of years and years and decades of ignoring health until the end, or being centric to one particular disease. COVID is attacking all of our metabolic diseases and all of those at risk. And I think to outthink a virus that really doesn't think too much but keeps it simple, we have to keep it simple. Let's screen people. Let's look at them as an organ, as a person. Person-centric assessment is probably, for me, where I would like to see things going. I think it's what the Lancet Commission leans to. It's multi-morbidity management. Let's make it person-centric, because the spend becomes about the person rather than the silo parts of that person. As Donna says, treat me, the patient, not me, the disease.
Very good points, Louise. And just to carry that thought a little further, I've mentioned some hard outcomes, liver-specific or stroke, for example, but of course quality of life, and we've touched on this a number of times, is strongly associated with the disease stage, fibrosis stage, particular end stage, but also inflammatory activity. And there's been a number of meta-analysis linking NAFLD independently of other comorbidities to quality of life, and there is clear evidence that this is affected. Now, that's another difficult part to assess, and the benefit to be quantitated, it always comes down to, are you using the right tool? Is that tool validated in that respective population? And in health economies, I know that there's a lot of calculations related to loss of productivity or being away from work, which you can then quantitate and calculate economic losses. And to me, from what I see from the literature and what I understand from the published analysis, there's a considerate burden in that arena here located. It's not only the physical part of being sick, but the loss of quality of life, the inability to care for others. Now, how much of that is strictly related to the liver instead of being obese or diabetes? For the single patient, it doesn't matter. For cost analysis, maybe it's more important to decide where to invest on. What should we improve? It's an important aspect of NAFLD.
Jörn, as I was listening to Louise and then listening to you, I had 2 or 3 thoughts. Let me go back to Louise first. Louise, politics in this country at least have become so horribly conflated that what I think happened in the case you talked about was that when your colleague said we should do health training around diet, what the school administrators heard was that the kids were going to decide that we were doing training because there were obese kids in class, and therefore the obese kids would get picked on and it would turn into a big body shaming exercise, right?
Quite possibly.
That's the logic I'm driving. And that actually speaks to a lack of visualization about what a curriculum would be. Because if you start the curriculum about the idea of how many of us are jeopardized, the jeopardy is not a function of weight per se, but it's a function of a whole bunch of things. You can reframe the beginning of the argument and maybe take the stigma out of it if that's what you know you need to do, instead of throwing up your hands and saying, oh my gosh, parents are on me for everything. It'll just be one more thing. That's thought number 1. Jörn, thought number 2 is that Alina Allen, when we spoke with her last week, mentioned an idea that I'd not seen previously in healthcare, but you see all the time in marketing, which is AI based on secondary database. And specifically, the question was, if we're going to go down a multidisciplinary pathway and start in primary care, given how time is allocated in primary care practices, how can we be confident that we can get a first step that works? And instead of coming back and saying, well, gee, we could determine that one of the tests we have right now is much better than FIB4, what she said was, well, maybe we could go into the databases and analyze for the characteristics, fundamentally turning electronic medical records into a huge AI database, which struck me as brilliant. We've got privacy protections in all these societies that may make it impossible ever to do it.
Yes.
But if you could, it would address a lot of issues. And I mention that because you're kind of asking, where do you start also?
Absolutely. You raised the important point that those patients are mostly, and I mentioned, not diagnosed. They're probably mostly with primary care physicians. And as colleagues here have highlighted, there's a tremendous pressure on primary care physicians to do everything they can do in those 15 minutes they have for the patient. So I support the idea of using tools to assist potentially the physician or maybe even the reception handling the patient's appointments in highlighting and flagging out the patient that this is somebody at risk of liver disease. And there's 2 algorithms that we actually build and use to study. And one is published by now, which is the Nash Map Algorithm that uses 14 variables to actually identify patients at risk of NAFLD and then could trigger the referral. Now, to be more precise, it's not identifying patients at risk of NAFLD, it's by identifying patients at risk of NASH. So independent of the fibrosis stages, this could be one lean way to flag them them for future referral. There's another study that we did build on that, and I think it takes a little different approach in terms of that's a retrospective database exploration of the NADDK and the Optum electronic healthcare records. And it's an algorithm that was built to identify those patients that progressed to cirrhosis within 3 years of being initially diagnosed. We call that population a fast progressor population. Both algorithms were developed and have good metrics to identify these patients, and there's a clear advantage to run them in the back end of, let's say, primary care healthcare provider or primary care physicians databases, not giving the data out, but keeping it into the office and then making an appointment or referral or flagging up these patients and for once in their lifetime saying, this person should be evaluated for liver disease.
Is the lean progressor analysis a one-time?
That was called fast progressor. It does include the BMI as a risk factor. The algorithm actually pulled from the big Optum electronic healthcare database 44 features. So it's a complex algorithm, much more than FIB4 could do. But based on the availability of all that data, when such an approach is feasible, yes, it was built as a one-time assessment to predict someone as either fast or standard progressor. But I agree, and I guess the question you're asking, if you rerun that algorithm every time the patient comes and you build information on changes of these data points, that's even stronger. My perception where you haven't done that is that you're going to get more precise predictions of the future in these cases.
I want to thank you for editing me with a level of intelligence I don't have, because that wasn't the question behind my question. I hadn't thought it through nearly that well, but thank you. Louise, go ahead.
Can you do that and age stratify that so that you could do that at a young age when people present as adolescents and then look like the FIB4, I think, is over 35 and under 65, for example. Is there a way to risk stratify it by age? Would it change, or does it just say that we'd have less tolerance as younger because by the time you get serial years of additional fat or whatever? Has that been done?
That's interesting too. And again, I detailed two algorithms that are a little different. The first one identifying NASH, and actually, as a matter of fact, age was not included in that algorithm. So gender was in liver function tests and HbA1c, but not age. So the first algorithm we called Nash Map was independent of age in that context. And we haven't looked at different age groups now. We know age affects fibrosis stage, not so strongly the presence of NASH, but it's something that could, of course, be done. For the fast NASH progressors, yes, these patients were generally older if they reached endpoints. And if you look at that stratified by age, I can't give you the numbers, but for sure, bottom line, age is a risk factor for advanced disease. If we focus on wanting to identify patients that reach endpoints faster or are more advanced, I think from a government or politician's perspective, we could choose an age cutoff to start screening for liver disease. Now, you're going to lose some of the power to counsel them in terms of avoidance or improving over time. And you mentioned, and I agree, that time is the best ally to try to prevent something or revert certain stages. If we identify them late, we might have a tougher task. And I think parts because the disease progressed based on biology and maybe the scar is built up stronger. But the other aspect is that certain habits that build over time are more difficult to change when you get older. There's something to even behavior psychology in this equation.
Yeah, I was just thinking, because if I was looking at younger, I would be looking for dental health. We know that dental health, and particularly in children, really indicate high sugar intake, poor diet. If that was added to an assessment, a 10-year-old with bad teeth would be ranking higher on my scoring system to be looking earlier for disease, the same as a 15-year-old, and progressing through that. So those are the other metrics that I would sort of think to look at outcomes. Dental caries, all of that gastric side that's easily quantifiable. But I'm not too sure how many GPs or particularly log it. I don't think I've ever seen it in a medical assessment in a hospital when we're assessing liver patients. I've never seen mouth, oral, dental hygiene, even on the assessment. And yet we know it's intrinsic. There's a figure, and I don't know where it's come from. You're 7 times more likely to get liver cancer with bad teeth. So yet it's the one thing that I've never seen in medical records of anybody.
It's interesting. When I said bad teeth, I went to endocarditis. So again, we're in one of these places where something that could be readily observed and isn't could provide all kinds of data. To some degree, this speaks to the idea that we don't have a really integrated view of the human system as a health system. Because if we did, then we'd be able to, like you say, Louise, check it like a car. But we don't think of it that way. I'm not sure we have it. And that's one reason a lot of this stuff slips through. Jörn, what are things we can do in the next year or 5 years, let's just say, or 2 years, pick the duration of your choice, but not 20 years, that will put us on a better track on these issues?
There's a lot of things that could be done. As a hepatologist, we will see more focus on the advanced disease stages. Those are the patients imperative to our care, cirrhotic or pre-cirrhotic patients. We'll see more studies on being performed in patients with cirrhosis because the cirrhosis burden is increasing. So from the physician's perspective, that is important. The standpoints the FDA are taking that highlighting that endpoints could be derived from cirrhotic trials will lead us to a situation where this patient population that needs urgent medical care will be included in one of the labels that's to come. We'll see more cirrhotic trials, which is reassuring, and that will have an advancement here in terms of treatment. The points that have been made here by Louise and yourself that screening for liver disease is something that's beneficial in the long term, I totally support, but I can't see that happening at this time point because, as I said, I think the competing risks are so difficult and the models we're using to estimate health benefit, it's difficult to capture that benefit over such a long time. So in the end, it might end up, just saying we need to talk to kids about healthy, balanced nutrition, but we cannot spend money on screening for liver disease, which is undoubtedly the mirror of the metabolism and can be assessed easily. I can see money going there just these next days. I'm not saying that I'm not supportive of it, but I think that these funds are going to probably be spent different. Now, circling back to the idea of AI-supported algorithms, if we leverage on all the incredible amount of data that's being captured in an electronic healthcare record at one physician's office, this could really be an advantage. Instead of spending additional money for tests and sending them off, having algorithms that define at-risk patients for different outcomes, but also for liver disease being run in the back end, this, without spending a lot of money additionally, will really improve detection rates and excel the field.
First of all, I totally agree with you. I don't believe that any society in the world is prepared to spend the kind of money you have to spend for a global screen. I would focus instead on screening everybody who met criteria that told us that they were at meaningful risk. So if Splendor tells us that by having bariatric surgery and losing 20% of your body weight, if in fact you're obese enough to need that, you can cause a 4-fold decrease in your mallow risk over 10 years and a 2-fold decrease in your MACE risk over 10 years. And what that literally means is that of every 100 patients, 7.25 fewer will have each of those two things occur in the next 10 years of their lives. I think that's easy to do the numbers for. I got to tell you, type 2 diabetes, tougher, but Muslims produce those numbers right in the States. So we could think about a strategy that at one level, Jörn, is the thing Alina mentioned and you just referred to, where we use electronic health records simply to infer what we can about patients. And sometimes that'll set off a big red warning light, and then we do something, and other times we just coach differently. And then there are places on the way there where patients will exhibit something that becomes that big red flashing light, right? A certain BMI level over a 6-month period, type 2 diabetes. There are a few others, and that might warrant a greater level of action. And no, Louise, it's not the kind of thing you'd hope for, but it's probably the best that can be done.
On the other hand, to maybe not discard that thought totally, I mentioned a group of medical students here in Germany that approached me to address school kids and talk about healthy cooking and go to their school and actually help them do a cooking class at their school and invite someone over to talk about metabolic health and the value of a healthy liver to them, and for them to bring it home to their parents and actually, tell them about this. Even if the parents don't have access to this type of information, using the children as part of the education and amplifying this in their family could be a very attractive way. Now, that project, unfortunately, under COVID has come to a pause because they're not able to visit the schools anymore. But these types of commitments and let's call it pilot initiatives are very helpful to raise the awareness and go out into the community, something that physicians could not achieve, something that a healthcare system could not achieve. You need those pilots, and that's why I'm very supportive of these type of activities. And there are many good things going on at the local community level.
And I agree. If I had a magic wand, we'd be screening and assessing and being person-centric so that you get that holistic view. Do I believe the money will come to do that? No, I don't. But I'd look at a pincer movement that you start with some of the higher risk younger people and you start at the other end so that you're bringing it down so that you meet in the middle somewhere eventually, and therefore you locate eradicate your highest burden, and we all know the at-risk groups discussed today, but also that we start to change, because there is a lot more momentum, there is a lot more discussion about becoming wellness, and we all know that most healthcare systems are set around illness and treating the disease when it becomes ill. That's what health service is. It's not a health service, an illness service. It's just the wrong way round thing. If it was about health, it would be all about prevention and promotion rather than dealing with the result of ill health. Therefore, those costs, that is a huge cost system. Is all of the money spent accurately? No, it's not. We have all worked in those systems for years, and there is a lot of waste. It's not run like a proper business. If I think to the NHS, I would get my budget 3 months into the year for the next 9 months. You cannot run a health service on a 1-year budget. No major company runs that, and that's from the NHS. Each part has a pocket of money. Oh, if I don't use my money, it's stripped next month. You cannot do that. It just doesn't make sense when we're trying to put money into being cost effective and being upfront. I'd like to see some of that money redeployed into a more person-centric format. I think we're going to go that way a little bit with integrated care pathways here, but if liver is not in the discussion as they're talking about integrated care pathways until later on, then we're not integrated. And we've missed one of the biggest pieces of the jigsaw, particularly for NCDs like cardiovascular disease, type 2 diabetes, and stroke, and all of those other ones that we know are linked. If we don't get that voice at the table, which is being driven now at WHO level into our purchasers and our commissioners, no matter which country you're in, you won't start to address the long-term costs, and lots of people will lead poorer quality lives and shorter lives as a result. So we do need to think, if you are sitting around a table designing pathways today in any part of the world and you do not consider the whole of the body and how it interacts with each major system as part of your pathway, you're missing it. Your body is an integrated care pathway. It is the world's best integrated care pathway, and yet we decide to break it all up into its chunks and try and put it back together in a different way. So that's what I'd ask, is that people put their pathways together in a way that one cog fits the next cog, because if you miss out one of those cogs, they all fall to pieces at the end of it.
Yeah, my last comment here, Roger, and I echo Louise, the siloed healthcare, it's difficult to overcome because we have so many experts in these silos and everybody provides their care to this own silo. All experts see that there's a clear benefit to improve all the aspects, and maybe liver is the mirror you need to have a metabolically healthy person. My last comment is what I think will be seen for 2022 and what's going to be carried on. COVID has changed so many things, and the need for testing, staying healthy, using health apps and health passes to monitor health is something that will really stay for good. Unlike COVID, going to the future, we're going to use healthcare information and have maybe more health consciousness. That's my positive take from COVID. Educate people on the risk and have it actually have a health metabolism pass on their phone to be shown at certain instances or give feedback. So I think this is something that we can carry forward. Maybe not develop in the full extent next year, but in the years to come.
So I think that's a great note on which to close, Jörn. Except I'm going to reserve one comment for myself, which is, Louise, listening to you talk about the body as the ultimate integrated health system that we keep putting into little pieces, I had never thought of the human body as Humpty Dumpty before that moment, but it really works, right? Except it's not all the king's horses and all the king's men. It's all the doctors and all the hospitals and healthcares. But if you adequately disintegrate the human system, it's hard to reintegrate it. One organ pops out, one disease pops out, something pops out.
Well, I think that's true. And when you get something that doesn't work, whether it's a liver disease, whether it's another condition, it's something in that integrated pathway that's not working. And therefore, it has knock-on effects into different organs, whether it's cystic fibrosis, whether or not it's any disease. And it's about where does it fit in that integrated process. The body is very good at adapting. We know the liver is arguably the best at adapting because it's the only thing that regenerates. If one thing goes out of kilter, we can try and replace it, we can try and remove it. But if we don't look at it in its context, no matter how specialised we are, and there are people who just do one pathway of the liver, cholesterol mechanism, just one part of it for their entire career. But that's not how the body has to do it. It is your total integrated machine. And we look at how to target the bits that are wrong. We look at, obviously, at the liver, we're partial to that, but we see it as a holistic organ that is integrated in most other people's pathways. What we don't get is reciprocation in that at the moment because of that silo. The body in its entirety is your best integrated care system. Let's look at it that way. Let's treat it that way. Let's assess it that way. And maybe we'll find the little bits of the integration that we need to target to help the individual.
You want anything else, or are you good?
I'm good. Roger, coming to an end, I think I'd like to really thank you for the opportunity to participate in Surfing NASH here in 2021. It's been my highlight for a Monday evening where the week is starting off, and was unable to join any colleagues for in-face meetings. So really appreciate I could contribute. You're listening to what I think and have to say here and be able to reach others with this. It's been tremendous fun, and I hope to be able to join you guys again next year.
Certainly, Jörn. And as your influence spreads through some of the work that you're doing with Jeff Lazarus and some of the other things, and having your voice a little more on this podcast isn't going to hurt. I think you've got a tremendous contribution to make and really great vision and field and all that. And you bring exceptional value every time you show up on this podcast. So I hope that if you ever have a chance to go face-to-face with your colleagues on a regular basis again, this stays on your dance card as compared to falls off in favor of those things. It's been a great conversation. It's been a great year. Louise, thank you for Humpty Dumpty. That image is not going to leave me quickly. And now I'm trying to figure out how you define the wall in the context of the healthcare system, but somewhere in here there's a cartoon. See you in January.
Same to you, Booms.
Merry Christmas.
Okay, my friend, have a great holiday. Merry Christmas, Happy New Year, and we'll be back.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please send an email to questions@surfingnash.com. And please join me again tomorrow, December 31st, for episode 64, our conversations with Stephen Harrison, Jeff Lazarus, and Andrew Scott.